It is the art and science of medicine as related to the performance of diagnostic and invasive therapeutic procedures that require additional training and expertise. This is what is important. This additional training and expertise that is required is beyond that required for a standard pulmonary medicine training program. So your routine pulmonary medicine training program is not equipped for all of this. So that is why you require an additional training or an expertise for these procedures. So broadly, I have divided them into diagnostic and therapeutic procedures. So common things that we do is endobronchial ultrasound or EBUS. And through your EBUS, we can do a multiple other options. There's something called as endobronchial ultrasound guided transbronchial mediastinal cryobiopsy. TBMC is for transbronchial mediastinal cryobiopsy. TBLC stands for transbronchial lung cryobiopsy. And peripheral pulmonary nodule sampling. So lung cryobiopsy is, we have discussed this in an ILD chapter, wherein you have to do a gold standard for the diagnosis of ILD is a lung biopsy. After doing an MDD, you decide on a lung biopsy. That lung biopsy will tell you what is the features that are there. Okay. Until the best diagnostic yield was considered was for surgical lung biopsy. But now we have minimally invasive, which is bronchoscopic biopsy using a cryoprobe. So that is what is transbronchial lung cryobiopsy. Then you have peripheral pulmonary nodule. I'll come to what is peripheral pulmonary nodule. We have discussed this in our lung cancer screening chapter itself. Peripheral pulmonary nodule in detail we have discussed. Then we have therapeutic procedures, which are mainly foreign body, stenting, debulking, and balloon dilatation. I'll show you what all these are. Okay, I'll show you mainly videos here. Okay, this is a summary of whatever I'm going to discuss now. So just pay attention to what I'm trying to highlight. So first we have is one device called as linear EBUS or a normal EBUS TBN. It is called as transbronchial needle aspiration. N stands for needle aspiration. So in that we just have a bronchoscope and we have a needle that goes inside a node. Okay, it is going under guidance. So the main uses that we have is for mediastinal staging and diagnosis of lung malignancies. Apart from this, you can use it for rarely you can use it for cyst aspiration. So if you have some mediastinal cyst, you can use them for cyst aspirations. So this is with respect to your EBUS TBNA. Routinely, it is used only for nodal sampling, mainly for lymph node sampling. So any unexplained mediastinal lymphadenopathy, if you have, even in those conditions, you can use them. So what are the relative absolute contraindication is a hemodynamic instability. Relative contraindications are if they have an elevated INR or a platelet below 50,000. But this is not absolute. We have done even at 1,000 or 10,000 platelets. Especially like if you have lymphoma, leukemia cases, in those conditions you will have to do. You just transfuse on during procedure, you transfuse platelets and continue doing them. So the overall yield for a EBUS TBN is somewhere 80 to 90%. This is at the maximum high volume centers. Otherwise, somewhere it is about 70 to 80%. So this is what it is. Okay. Whereas if you take sarcoidosis, for example, you can use even in ILD. So let us say sarcoidosis. It is both a parenchymal as well as a nodal disease. In sarcoidosis, the diagnostic yield is 75 to 80%. Okay. If you use TBNA alone, if you add endobronchial biopsy is normal bronchus is there. As you go, you just blindly take some biopsies. This adds another additional 10 to 20%. Okay. And if you have transbronchial lung biopsy, TBLB, it is called as. So blindly I go and based on CT, I say, okay, this part of the lung seems to be damaged. I go there with the probe and take a biopsy. So that will add additional 10% yield. So 10 to 40% is the yield that we can have. So the combined yield of all three, EBUS, EBB plus TBLB, is somewhere about 90%. somewhere nearly 90 to 94%. This is a combined yield in sarcoidosis. Okay, so that is with respect to sarcoid. Then you have something called as mediastinal cryobiopsy. So what I'll do is I'll directly show you the procedure. Then maybe we can jump into the theory part of it. Okay. So you see, this is usually a PET scan that is done before. Okay. So what we are seeing in the PET scan here is you are seeing a mass here and you are seeing a mediastinal lymph node here that is having a high FDG uptake. So if you are going to think all FDG uptake is going to be malignant, definitely no. The SUV max that we calculate for it, we calculate as an SUV max. So usually they say is more than 2.5 is having high avidity, but well established is that any inflammatory diseases like simple TB also can have elevations. Therefore, it is not having sensitivity or specificity. So what they are doing is you are having a bronchoscope, normal bronchoscope, and the tip of it is having an ultrasound probe attached. So what you are going to do is you are going to see the airway like this. If you're not finding anything, you will activate the ultrasound. You are going to see the node that way. You will take in a needle there. This is a needle. And as you're seeing there, you see that? So this needle, so once you screen the node this way, you can pass the needle through and through. And you can take multiple FNA passes of that. So you see this is the needle. And then what you are seeing is they're applying a suction. Okay. So what people have done is they have seen when you are doing this, if you apply, let us say 5 mm versus 10 mm versus 20 mm suction, is there any change in the diagnostic yield? They have found that changing any amount of suction is not going to change any diagnostic yield. One. Second thing is more is the amount of suction you apply, more is the amount of hemorrhage that comes. And that will dilute whatever you can see as well. So routinely you don't have to apply suction. Okay. So what they'll do is you see you have applied suction and multiple throws, they just agitate continuously. And then it is you put it on a slide there. Okay, you place it on a slide and on table itself you can do this. So that is what is called as ROSE. It is called as rapid on-site evaluation, ROSE. Okay, it is called as ROSE, rapid on-site evaluation. If you're going to ask, is this going to have any diagnostic yield? Definitely no. So what it does is, it is, let us say the number of times you have to sample the node, it will reduce that, and the number of length of the duration of procedure, it will reduce. So that is what ROSE does. So you see, you're going to see it in the microscope directly. So that is what is your EBUS TBNA. Okay. So then when you're applying ROSE, what it does is it reduces the duration of procedures. Okay, so time required for procedure and number of passes are going to reduce. And no change in diagnostic yield. No change in the diagnostic yield. So this is with respect to ROSE. It can be done by the pulmonologist or it can be done by the pathologist. If pulmonologist is going to do it, it is called as pulmonologist administered ROSE, also called as PROSE. Okay, so that is what you have. And what is the number of passes? Minimally, how many number of pass is minimally recommended? Is minimum is at least 4. 4 to 5 is minimally recommended. Why? Because normally what you do, especially in lung cancer, etc., what you do is one pass will go to the pathologist. Okay. One pass will go to the microbiologist for CBNAT, gene expert, etc. So one will go to micro. Then you have one more pass plus one more. So what is this additional passes? You go for screening. Especially like let us say you're seeing some malignant cells, etc. Okay. So if that is present, then what you do is you need advanced NGS testing or you want to do an IHC on them. Then you require additional samples because you want to look for driver mutations like we have seen. All of that you need these advanced tests. So that is why minimum 4 to 5 is what is recommended. Okay. So patho, micro, biochem as well as IHC markers. So that is the minimum amount required is 4 to 5 samples. Okay. And we have seen in the previous sessions on when to do a staging. So we have seen, four options. So central tumor or the size is more than 3 centimeter then you have to do a sampling. If it is a peripheral tumor and if there is no N1 disease, then you don't have to do a sampling. Or if you are not able to see difference between the mass as well as the node, then also there is no point in sampling. So this is with respect to mediastinal EBUS TBNA, it is called as transbronchial needle aspiration. Now you see this. You're seeing here, there is one big nodule here, okay? Mass or nodule you can call. So what you are doing is, we have something an advanced technique. So normally you will just take the bronchoscope there and then you will put in some other radial lever. So I'll show you what is going to happen. You will place another endobronchial ultrasound device that has a 360-degree turning. So it keeps on rotating 360-degree and it will recreate the airway map for you. Okay. But however, that is not real-time sampling. So I'll show you the videos there subsequently. So how to reach that path target? So that lesion is there somewhere. So how do I know whether the route I'm going is correct or no? Because you see, this is the main carina here. Then right main, left main. You have so many and subsequent divisions that is going to happen. So that is when it becomes difficult. So what it does, you see this is the software, AI, wherein it is saying it is going to take you to the appropriate area. So this is in the subsegment of some lobe, okay? So you see, this is that probe that I was telling you. So 360-degree rotation will show you. So it's called as concentric image. So this is a probe is in the center and surrounding 360-degree, there are some lesions that the probe is noticing. You see, these are abnormal lesions. What you'll do is you'll take a node, you'll take a cryo node and you can sample these lesions. I tell you. So the main complication here will be bleeding. Once you're taking a biopsy from the node or from the lung itself, this is not a node, this is from the actual lung tissue itself. So as you take, it will bleed. So to prevent this bleeding, you will inflate something called as a Fogarty endobronchial balloon. Okay, what is this called as? Fogarty's balloon. Okay. Fogarty endobronchial blocker. This is a nodule. So somewhere, so if you see here, so somewhere this is the right left main bronchus, the right main bronchus. This is the anterior portion. Okay, so this is the upper lobe. So this is the upper lobe. So anterior. So you have anterior, posterior, and apical segments in the upper lobe. Okay, so this is somewhere posterior. This is a major feature. So likely it is your posterior segment, RB2 or RB3 maybe. Okay, so you see this bronchus intermedius. This is posterior segment. Subsegment you're going. You're placing this. This is the radial EBUS probe, confirming your concentric image. And then let us say you're going to sample it. So you're going to place this balloon. This balloon is called as Fogarty's balloon. So you see here, they are taking the sample, they have inflated it. This is under fluoroscopic guidance. So you see under fluoroscopic guidance what they are doing. Observe carefully. They have taken a tissue. This is using a cryo probe. Okay. I'll show it again. You see it once. You see here. So this is the probe inside. You see, this is the tissue. Okay. So this is a cryo probe. Okay. This is just like a sample that is there. So cryo probe means, like the name suggests, it is cryo. That means it will freeze the tissue. Because it is freezing the tissue, the advantage is it will preserve the architecture. So you will not have any crush artifact. And the sample that you use, if you are using a cryo probe, it will be a very big tissue. So you can use advanced testing as well on that. And the larger is the tissue, you will feel more confident with the diagnosis. Okay, so that is why people use a cryo. So you see, you will freeze the tissue for about 5 seconds and then yank it. You see, they're forcefully pull it now. You see him, he's forcefully pulling it. So it is just gone. And you see the size of the tissue, it is a huge size of the tissue that you have got. And then what is it showing? You see here, these are atypical cells. The atypical cells for squamous cell carcinoma. So that is what you have here. So that is why it is very important to know it. Okay. Atypical cells that are seen. So what are the balloons name? They may ask you. It is called as Fogarty embolectomy catheter. Previously, it was used for embolectomies in peripheral vascular disease, no? If you have a venous clot or an arterial clot, if you want to do an embolectomy, then you use this Fogarty catheter. Okay, so this is Fogarty's endobronchial balloon. So this we have seen. Okay, next we'll go to the next modality. So I'll come to each of this maybe in detail. So once you see this, you will be able to get an orientation. Okay. Okay. Anyway, then I'll show you all the modalities and then I'll discuss each of them in detail. So this is one more modality, just to show you Fogarty balloon placement. Okay. So normally it is going to be placed this way. Somehow this is not playing. I'm not sure why it is not playing. And we have seen how it is placed. Okay. This is something very interesting. You see, this is so you're doing a bronchoscopy. If you're not in bronchoscopy, it is difficult to identify. So what I'm seeing here is the fistula that is there. Okay, so you'll identify it based on some techniques that you see here. This is the carina you're seeing. If you see more properly, you will see this is the esophagus. Okay, the esophagus. And as I'm going down, you are seeing here, this is the bronchus that you are seeing. Basically, as I'm going, this is my bronchoscope. So I'm basically entering inside the pharynx and going into the bronchus. But what I'm seeing is a large opening communication here. So I have to block it to prevent. So this is a rigid bronchoscope. You're seeing this is a metal barrel that you're seeing. This is a normal bronchoscope, the rigid bronchoscope barrel. Okay. So I'll show you parts of that also in case they ask you. Maybe in your Viva, if you're giving for pulmonology, they'll definitely ask you. You see, this is the port where your ventilator is connected. Okay. This is the port wherein you have your, this is a suction port. Okay. You can attach suction to it, or you can attach your Fogarty balloon. All of this you can put it here. This is your normal working port or a channel wherein you are using a flexible bronchoscope. This is called as a prism. It has not much use. In previously, what they used to do was there was no light source properly in the scope. So what they used to do was they used to use a principle of total internal reflection. So you adjust the prism such that light will internally reflect and you will be able to see inside. Because rigid bronchoscope or tracheoscope was used for removing foreign bodies by ENT surgeon. Mainly it was given by Chevalier Jackson. So that is the use. So they are using it here. So they're going and seeing it. Okay. You see, this you have to time where it has to be placed. So this is a stent. Okay, this is a stent. You see, they are deploying a stent. So they have, with the fluoro guidance, they have seen, okay, this is the point where optimal deployment, if you do, you will completely close the area. So you have, this is the trachea, this is the esophagus, let us say. This is communicating. So they go and close up the trachea with a covered stent. So you see, this is a metallic stent. Okay, this is a metallic stent, and it is a covering from outside. So whatever is there from outside will not enter inside. So it is going to act like a conduit. Okay, it will prevent a trachea and esophagus to communicate. And you see, you're going and confirming that the carina is normal in patent. Very important is whenever you're putting a stent, you should see that if this is my stent, the distal part has to be patent. Let us say when you're doing a bronchoscope, you are not able to see distal part at all. So in that instance, even if you put in a stent, it is going to fail because you have not treated the underlying cause, which is a obstruction over there. Okay, so you see, you can see it here. Very bad. This is okay. Very, very huge stent. This one here, fistula here. So what people have done is in the army, right? So what people have done is they've even used an ASD closure device. So if it is a very large, this one, right, opening, and let us say stent cannot be placed. Let us say if it is higher up, then it is very difficult to place a stent just below the subglottic area. In those instances, what you can do is you can go into the bronchoscope and put in a ASD closure device. You have an outer part which have a bigger ring and inner part that has a smaller ring. So then you place that there and fix it up there. So that is with respect to tracheoesophageal fistula. It can be both benign or malignant. Most of the time, benign is because of TB, where lymph node will erode. So in those instances, instead of putting a stent, because metallic stent, the moment you place a metallic stent, removing that is very difficult because it is a foreign substance. It will prevent your normal mucociliary clearance. It will increase cough, etc. So most of the time, stenting is a palliative procedure and never a therapeutic procedure. So whenever you're doing stenting, it is just to relieve the symptoms. If the patient is not having symptoms, no stenting, even if you're seeing something abnormal. One. Second thing, in a benign disease, you don't put in a metallic stent, you put in always a silicon stent. Okay. Second thing. Third thing, as much as possible, try conservative management in a benign disease. Okay. So what you can do is you can start ATT, the lymph node size will come down, and then patient will become fine on their own. So that is with respect to your this one, stenting. Then this is a very, very interesting procedure, very gratifying as well. So these kind of patients, this is a carina. Okay, so what is we are seeing here is this is a carina, main carina. This is a right main bronchus, this is a left main bronchus. So you have a polypoidal growth in the carina extending into the opening of the right main and well as the right main and the left main bronchus, more into the left main than right main. So this is a suction port we are keeping with a rigid bronchoscope. Metal is a rigid bronchoscope. Then we are placing a Fogarty balloon because whenever you have a carinal tumors, they bleed like anything. One. Second thing is if you are playing with the carina and if it bleeds and you're not able to secure the airway, continuously it will bleed into both the airways. So that is why you should be very careful when you're dealing with carinal tumors. So that is why even biopsy at the level of carina is routinely not recommended unless and until that is the only option left. Okay, so then they are taking a device called as a snare. Okay, so what they will do is they'll put in a loop. Okay, so they will put in a loop around it, and once they put in a loop, they will apply a current. So that current will cut the tissue, and along with it, it will coagulate the tissue. It is like a cut and coagulate, and then they'll bring out the tissue completely. So this is what is called as debulking of the tumor. So they have removed the bulk of the tissue, and you see here it is bleeding. Okay, look out the bleed. So it has bled properly, but then the entire bronchial tree is fully patent. So what they are doing is they are just removing whatever is remaining, and the base of the tumor they are putting a electric current, this is electrocautery, and see what they have done here. As they are applying electrocautery, the balloon that is placed here continues to remain placed, so that it will prevent further spillage from happening. And then they are doing something called as mechanical debulking. So you can use a rigid bronchoscope. So it is a metal, right? It will have a sharp end, just like how your syringe is very small and a bevel. Same like that, this is a bigger one with a bevel. So what you'll do is you'll do something called as this called as scoring or mechanical debulking. So as you turn, it will cut through the tissue and go. Okay. So whatever is remaining, you have cut it through, and then you will to prevent the further growth. So at the level of carina, you will put in a vice stent. This is a vice stent. See, they are deploying it. It's called a single guide wire technique. So how do you know which side you are going to deploy? Right side, left side. So what they'll do is they'll take a guide wire. So that will be in one side. So you know, okay, that means we are inside the guide wire. So it has gone into the left main. And then slowly they'll deploy it. As they're deploying it, you see this will open slowly. Under vision, they are doing it. So this is also very important. Whatever you are doing has to be under vision. If you're not doing it under vision, you will be land into a lot of problems later. And then you'll see whether it has opened completely. Because it is not opened completely, you see what they've done. This is a balloon. So it's called as controlled radial expansion balloon. I don't think it is very important for you. It is called a CRE balloon, controlled radial expansion balloon. It's called a CRE or controlled radial expansion balloon. So what will happen is it. So what is the difference between this and Fogarty balloon? You ask the same question. Both are balloon. So what is the difference? So the difference is that In Fogarty balloon, it is not a very stiff balloon. So from inside, if you put a lot of pressure, it will move it. Whereas this has a metallic component to it. So the more you stretch it, it will not deform. It is not very easily deformable. It will stay like that only. So that is what it is called as, and it exerts an outward pressure. And what is the pressure that you cook? So you keep an amount of X amount of atmosphere. So you will just dilate and see what is the size you require. Appropriately, you will keep 5, 6, 7, 8, 10, 12, etc. Okay, that is with respect to CRE balloon. Okay, so then why you are going to use this? You are using it if because it is not fully expanded, right? So then to open up the stent more better, you are using the CRE balloon. Okay, so that is what you have here. Because a balloon is used, stent is done, and you are having a completely clean trachea. So imagine patient coming in with stridor, and you have removed this and put in this. Patient will have significant relief in his symptoms. So that is what is called as tumor debulking. Okay. So these are the modalities that we had.